So good morning, everyone. I'm I think we're almost at 60 people, so I think we can probably get going. So I'm really happy to have these joint rounds, and I'm thinking maybe we should probably do this maybe once a year or something like that. It would be great. Um, I have nothing more to say than I'm really happy and looking forward to the presentation, and I will uh, give the floor to Jean-Martin to introduce our speaker this morning. So enjoy the talk, everyone.
Thank you, Melina. Many of people in the adult general surgery department may not know Dr. Emil very well, but he is a true global surgeon. But first and foremost, he's a global citizen. First, he was born in Egypt, with both of his parents being physicians who did volunteer work in Africa. In fact, he spent part of his youth growing up in Nigeria, and then was back in Cairo for high school. He then immigrated to the US as a teenager, studied engineering in Ann Arbor, and then was accepted in medical school here at McGill and graduated in 1991. He went back to the US for general surgery training at Loma Linda and a research fellowship at LA Children's. He returned to McGill for pediatric surgery training from 1999 to 2001, and then started his academic practice at the University of California in Irvine. In Southern California, Dr. Emil rapidly became a star, both in the departments of surgery and pediatrics, being recognized as the Physician of the Year at Miller Children's Hospital in 2002, and receiving multiple awards at UCI, both for teaching and for leadership. And actually, within a few years of starting there, he became chief of pediatric surgery at UCI in 2005. We were fortunate to recruit Dr. Emil back to Montreal Children's as the division chief in pediatric surgery in 2008. In fact, that's probably my best accomplishment of all my career, was to get him back here. And once he was here, again, he became rapidly involved in teaching and mentoring students. In 2012, he became the Associate Chair for Education and Departmental Citizenship in the Department of Pediatric Surgery. He recently stepped down as Division Chief after 16 years of great leadership and growth of our division. Sherif is an outspoken surgeon and patient advocate. He has pioneered patient and family-centered care, not only here at the MCH, but he has also authored the first chapter on this topic in the big 2-volume pediatric surgery textbook published in 2012. He lobbied very hard within the Department of Pediatric Surgery and at the hospital with the foundation, and helped to create the Saputo Chair in Pediatric Surgical Education and Patient and Family-Centered Care, which he has held since its inception. But coming back to global surgery, Sherif started going and organizing medical missions to several African countries, especially in Kenya, since he was a general surgery resident. Teaching has always been a high priority, both here and for surgeons in LMICs. After publishing his book, Clinical Pediatric Surgery, a case-based interactive approach, he managed to convince the publisher to give free copies to pediatric surgeons in low and middle income countries. After several African, I would call it inland missions, Dr. Emil started volunteering with the Mercy Ships organization. He joined the board of Mercy Ships Canada, and just very recently, in the last couple of months, accepted a half-time position as their international chief medical officer, a position that will be starting on January 1st. I'm sure you'll hear more about Mercy Ships during his talk. I cannot list all of Sherif's accomplishments, it would fill the hour, but suffice it to say that Dr. Emil is without question a surgeon with outstanding integrity and medical statesmanship, who is not only devoted to the highest principles of surgical practice, but also devoted to the dissemination of these principles through mentoring of medical students, residents, and acting as a role model for his peers, both here and abroad. So I'll let the floor to Sherif.
Thank you so much, Jean-Martin. Let me bring my presentation up. Okay, good morning, everyone. I have to say that Jean-Martin presenting me this morning is really a gift. I did not expect that. I think this is the first time this has ever happened. Usually I've been the one presenting him for different reasons. And so thank you. This is really special. It's a very special event, and I'm just so honored that you've taken the time to present me. And I want to thank Dr. Vasilio for giving me the forum to speak at this combined rounds. And really, I do hope, I second what you just said, I do hope we're able to do this more often. I think our departments would really benefit from some combined rounds at least a couple of times a year. And I hope this is not going to be, I hope this is going to be the first of many. I also do want to thank the administrative staff of the department, Carolina and Stephanie, working with Lily, our administrative secretary, to organize this joint rounds. So thank you all for getting us to this point. I do have to make some disclosures. Number of things I'll talk about today that I either have grants or some involvement with. Right now, I am the Mercy Ships International Pediatric Surgery Specialty Consultant. This is a volunteer position. I do not get paid. I also work with the Hendren Project. I have a Royal College grant, and I will talk a bit about the work that I've done with the publisher in terms of global surgery. At the conclusion of this presentation, I would like participants to be able to identify some really practical methods to transform good global surgery intentions. Because I think when we work in the global surgery field, we all have good intentions. But how can we translate that into good global surgery practices? And I really, truly approach this very humbly, because both in our Department of Pediatric Surgery and in the Department of Pediatric Surgery, there are absolute giants, people like Dr. Pinero, who just been named an Order of Canada recipient, and many others in the Department of Surgery who've really dedicated their life's work to this. So please do not see this as a formula that I'm trying to give and saying this is the way it should be done. I'm simply sharing a perspective after 25 years of engagement in many different venues of global surgery. It's not the only perspective. There are many others. There are some that could differ significantly from my perspective. So I just want to start by being clear that this is really a very personal journey that I'm sharing with you. And in many ways, it's not really just professional. Last month, I had a very emotional event. As Jean-Martin said, my parents left for Nigeria when they were very young. And I was 6 at the time. And the picture on the left there is with my Nigerian and Indian friends at my elementary school in 1971. And I just happened to be able to go back to the same town last month for the trick course that I'm going to speak about and visit my elementary school again and go and speak to one of the classes. And this is really part and parcel of it. I cannot differentiate my personal journey in global health and global surgery from my professional journey. They're both very intertwined. What is global surgery? There are many definitions. I like this very simple definition: a multidisciplinary enterprise seeking to provide improved and equitable, and we're going to come back again to this word equitable at the end, because I think it can really define a lot of what we do everywhere. Does not have to be in a low-income country or in Africa. But it's equitable surgical care to the world's population based around the central pillars of need, access, and quality. And what is the interest in global surgery? The interest is really quite tremendous in our environment. More than 30% of graduating medical students in 2010 had international education experience, and that number probably approaches 50% or more now. 2/3 of applicants to surgical residencies would be more interested in a program that offers an international training. And you know that a lot of US programs now have international rotations built into their curriculum. Most medical schools, certainly ours here, have established global health programs. I think McGill has one of the most vibrant and most well-known ones under the leadership of Madhu Pai. So this has become part and parcel of academic medicine. And when we look at surgical residents and explore their interest, a huge majority have an interest in global surgery. About 2/3, again, prefer to have international electives in their curriculum, and about 3/4 plan to incorporate some type of global surgery into their career. So this, again, probably more than any other specialty, if we think of global surgery as a discipline, probably more than any other discipline, really pervades our surgical training and practice. And multiple organizations have endorsed this. There's been publications to talk about the benefits for surgical residents, optimal function with limited resources, exposure to a wide variety of surgical pathology, exposure to a foreign culture. And probably the most important is forming relationships with local counterparts. It's all this, everything we do in global surgery starts and ends with relationships. That's really what it's all about. And when we talk about residents going or coming, it's not so much about them doing certain cases, or it really is about planting the seed of a relationship that often will continue to bear fruit for decades. In our own interest, in our own discipline of pediatric surgery, this is a reasonably recent study that showed that about half the surgeons, half the pediatric surgeons in North America have done some type of international work. Almost all of them are interested, and not just in terms of service, but are also interested in teaching global surgeons. So the interest is there. And then what is the need? Now, there's been a massive amount of literature, of course, about the need for surgery in low and middle income countries, how many operations still need to be done, the morbidity, the life loss, the disability that pertains to this. But just a few numbers to share with you. If we look at pediatric surgery, the number of practicing pediatric surgeons in the 5 largest US metropolitan areas, where there's about 3.5 million children, is about the same number of practicing pediatric surgeons in sub-Saharan Africa, which has 500 million children. That starts to give you a little bit of the gulf that exists in between. And this is a study that we participated in here at the Children's. It was a huge international study that involved about 60 or 70 countries, looking at where the countries stand in terms of their healthcare expenditures, how they're classified by the World Bank, and the morbidity and mortality of some of what really defines what we do, things like esophageal atresia, intestinal atresia, diaphragmatic hernias. And you can see that this difference, the disparity, really translates to mortality. Dan had done a study here at our center looking at pediatric surgical capacity, mostly in Africa. And you can see that there are a few spikes where there's a few countries that seem to have good numbers of surgeons. Most of them have extremely low number of surgeons. And when you actually look at the number who practice in the public system, because you could be a pediatric surgeon in sub-Saharan Africa and actually make a pretty good living still working in the private practice. But when you look at the number of surgeons working really in the public domain, it sometimes falls to near zero. So the capacity is still very significant. And then when we ask people, like, what is it that we can help with to establish capacity, you see that the top 5 requests have nothing to do with, going and operating or the kind of things we associate with global surgery. It really is about helping them with education, faculty development, scholarships, collaborations for trainee education, opportunities for overseas clinical training. That is what they feel they need. And this study actually left quite a bit of impression on me, because it has directed a lot of where I thought my effort should go. So the global surgery dilemma, in many ways, is how do we bring the interest and the need together? How do we align those two? Now, there's been a lot written, mostly in the last decade, but even well before, about where we can sometimes go wrong. This is an interesting commentary that was published by 4 military surgeons who happen to do quite a bit of overseas work, and it's a term that has taken quite a bit of hold in global surgery, global medicine in general, and they described what they call the 7 sins of humanitarian medicine. One is leaving a mess behind, going and doing something and not having partners, not having follow-up, and leaving a patient with significant morbidity. Mismatched technology, so bringing things that we use here and trying to employ them there, and then sometimes even leaving technology that is not going to be used or that can actually harm patients. Non-cooperation, lots of non-governmental organizations that sometimes are doing the same thing, and in some ways, sometimes actually compete with each other for patients to keep their organization going. Lack of follow-up, sometimes prioritizing politics over service, and that can be very, very toxic. Unwelcome guests, going to places where you're not invited.
Someone texted.
And then this is probably one of my favorite, doing the right thing for the wrong reason. Going and doing work to get credit, trying to do a first, trying to accomplish something that you can then come back and speak about, and you may have done some right things during the time, but if it's done for the wrong reason, it doesn't tend to help much. This is another paper that's been written about the aftermath of what's called global surgical colonization. And, this is an interesting paper. It was a Delphi survey between a number of surgeons, both in high-income countries and low-income countries, sort of reflecting about their experience and trying to come up with certain themes. I don't agree with everything, but it is very much worth looking into, and they identify 5 themes that that they feel need to be addressed. And I think, again, it's useful to go through those. Even though we call surgery global, is it really global? Because we come to it from a very, very much a Western standpoint. Geographies of inequity. Often the transfer of material and knowledge and everything is unidirectional from north to south. Unequal participation. We can overwhelm our guests sometimes because we come in and we, bring these large groups and large missions, and then we have very little participation from the local surgeons. And even though we might think we're bringing resources, sometimes we actually extract resources. We may extract trainees. We may extract nurses that are needed for other activities there. And then this is probably the one that rings the strongest, is there's significant asymmetry in power and in control. The funding, oftentimes publications that come out of this kind of work mostly flow toward the north. And so again, these are really important themes, I think, for people who are pondering how to get involved in global surgery, and I find this useful. Now, I'm going to forward 25 years from the time I was a child to when I first went back. As Jean-Martin said, I had just finished my training, and I went back to Kenya and Tanzania for a month, a few months after I completed general surgery, and I worked with 2 organizations. One was our mission hospital in Kenya, and one was AMREF, which is an organization supported by European countries that had a really interesting model of a Kenyan-based surgeon traveling to different district hospitals, some of them very remote, and really relying on the local physicians to both do the screening and the follow-up. And often we would operate on 40, 50 patients in 4 or 5 days. And that AMREF model really registered with me. I thought it was a very healthy model. In the middle here is Tom Rossen, a Dutch surgeon who had committed his career to being in Kenya. And you can see there is a Kenyan surgeon who we had taken with us. So really it was involving not just somebody who had come from outside the country, but whoever is available from the country as a resource. This was the local German surgeon who was staffing the district hospital in Loliondo, Tanzania, which is a very remote village, basically, and his wife. And the hospital was very basic, and it was really interesting for me to return a quarter century later and feel like time had stood still. This is the kind of place my parents worked in. You could get a malaria smear, you could get a CBC and some x-rays, and that was pretty much it. Very, very basic facilities. All the instruments had to be boiled. There was no pulse ox monitor. There was no ventilator. You could see the nurse anesthetist here providing anesthesia and using her left hand as the heart rate to monitor the heart rate and the temporal pulse, and using her eyes to look at the child's lips and make sure the child is not cyanotic. Tom was truly a general surgeon. In the week I spent with him, we worked on patients with cleft lips, thyroid goiters, fistulas from botched circumcisions, lots of hydatid cysts. I actually learned how to take care of hydatid cysts in that mission. And the beauty of it was that it really was a teamwork. We worked very closely with the local teams. And when I say we worked closely, I don't mean we just operated with them. We ate together, we had breakfast together, we discussed cases together. And then Tom left, I left with him, but he was always available for the local physicians who were following these patients to take care of any problems that happened. And I learned a lot through Tom's career. I got to meet him when I went back again. I've been back to Kenya multiple times. doing different things. And in 2023, last year, I looked him up and he wasn't operating anymore, but he was living in Kenya still, getting ready finally to return to the Netherlands after an entire life, basically in Kenya. And speaking with Tom, about his experience, and many of the things he did, he kept the way he was presenting himself. He would kept saying us Kenyans, us Kenyans, us Kenyans, and it really dawned on me that if you work in this field, it doesn't become about the color of your skin or where you were born or what language you grew up speaking. It's really who you identify with. And it was a beautiful example of how a very white Dutch surgeon can feel Kenyan and can really contribute their life's career to helping people in Kenya. And it was really, for me, an inspirational example of how we sometimes do not do well by increasing the number of labels that we like to give ourselves. In that same mission, I was fresh out of training. Of course, laparoscopic surgery, this was in the late 90s, was really booming. And there were only two surgeons in Kenya at the Aga Khan Hospital, which is really kind of the hospital of the rich, doing laparoscopic cholecystectomies and minor other surgeries. And nobody else had access to laparoscopic surgery. So I had recruited Olympus and Storz to give me literally thousands of dollars of equipment that I was able to take with me so that we could do the first laparoscopic cholecystectomies at our hospital. And we had a very, very, very successful experience over several weeks. In fact, it was so successful with such great outcomes that the surgeon who helped me in the first 10 cases asked me to then remove his gallbladder because he'd been really suffering from gallbladder disease and was waiting to go to a place where he could get a laparoscopic procedure. And I ended up removing his gallbladder. And then when that went well, the hospital's obstetrician asked me to remove his wife's gallbladder. So I did that before I left. So it was a great experience. I felt I did a really good job. I call this the first picture of Lab Chole graduates, but I didn't do a good job. I learned over time that this wasn't the best way to do it because I left. The surgeons I worked with thought that they had seen enough cases and they felt comfortable, and they went ahead and continued. And then shortly afterwards, there was a bad outcome because really of a lack of experience. So, I was very young. I didn't quite understand the full picture. But over time and looking back, I realized this is exactly the example of, sometimes doing the right things for the wrong reasons or not leaving the right legacy behind. And this event actually delayed the introduction of more laparoscopic techniques by probably at least a decade. Eventually, the surgeons got the appropriate training and I was back again last year, and now laparoscopic surgery is standard. But this is an example in my personal experience where I felt I did a really good job, and I really think I could have done I could have gone about it in a much better way. So now let's fast forward to something very recent, and really, again, informed, I think, by a lot of experiences. Many of you may know about the Trauma Resuscitation in Kids course. This was created by the Royal College in 2012. Now it's provided by the Canadian Association of Emergency Physicians. It's a 2-day simulation-centric course. It has replaced ATLS in many pediatric trauma centers, and it has been delivered 24 times throughout North America and only once outside in Brazil, really through the efforts of one of our global surgery fellows. So we applied for a Royal College grant, and the objective was to adapt the course to Brazilian and African needs and create a national and regional cadre of instructors who will then propagate the course in their countries and regions. And this is how we designed it. We designed it in 3 phases. The first one, of course, was to conduct the course, and then from the people who take the course, identify champions, train those champions to serve as the future instructors for their country or for the region, and then have them deliver the course with only the mentorship of one US or Canadian TRIC faculty member. And from the get-go, before we even filed our application, we looked for partners. And, we had multiple partners in Canada, from people who were very well versed in the course, and a very important partner with the Canadian Association of Emergency Physicians, because they own the course and they would have had to relinquish the fees and so on for us to be able to do this. But we also sought individuals in Africa and organizations that are well respected in Africa for their educational capacity and so on. And we wanted to pair this course, twin it to some of the national meetings so that people don't have to have extra expenses. They would already be coming to some of the national meetings, and they would just come a couple of days earlier. Almost all the national meetings have pre-meetings, workshops, or courses. So we were successful in the grant. It's a 3-year grant, $90,000, but we have about more than $500,000 of in-kind contributions, again, through the CAP, through people, coming from North America to Sub-Saharan Africa without expecting any compensation. And these are the countries we designated to do the course in. And we spent a good 6-7 months, starting with an introductory meeting between the North American and Nigerian faculty. I was in Freetown at the time on the Global Mercy, and there was a West African College of Surgeons meeting going on. So this was a great first meeting in person. And then we held regular Zoom meetings between the course faculty, our hosts, and the representative of the Association of Pediatric Surgeons of Nigeria and the West African College of Surgeons. We created a WhatsApp group, which came in extremely, extremely critically handy because 3 of the 4 faculty in Frankfurt, we arrived from different places ready to join our trip to Africa, and Lufthansa would not let us on because we thought we had visas when we actually didn't. We just had receipts. It was not clear at all from the visa application. And it took our hosts in Nigeria on a Saturday going to the highest echelons of the Ministry of Immigration to get us visas to be able to board our flights. But every single decision about course logistics and contents was made jointly by the Nigerian and North American partners. Nothing was designed by us without their input. And then to go to phase 2, we designated having more Nigerians and North Americans choosing the faculty that will then move on to become the instructors. And we laid out very clear criteria for how we're going to choose that because we imagined that almost everybody who took the course is going to be interested. And we did designate a stipend to help those surgeons with the time they will commit. And the grant has progressed very, very well. We've completed phase 2 in Brazil. Tentatively, we might be providing phase 3 in March of 2024. In Nigeria, we just completed phase 1. And we're now in the process of completing phase 2. In Kenya, we'll be giving the course as part of the Kenyan Association of Pediatric Surgical meeting in June. And we are currently speaking with the College of Southern, Eastern, and Central Africa for working with them to provide the course in Burundi in December of 2025. And for me, the beauty of this was really working with young people who were getting so excited to be able to host this course in their country. Students, young residents who were helping coordinate things. And, we had a sim center, but it was very, very basic. So we had no techs or anything like that. And they were really acting as the techs and filming the sessions. And it was really just such a pleasure to feel embedded in their environment and really feel like they're owning it. And the course went absolutely beautifully. We were able to adapt their environment to the trick and adapt the trick to their environment. And I'm going to play you a 1-minute presentation by the Secretary General of the Association of Pediatric Surgeons of Nigeria, because I think he puts it better than I can. And I'm going to advance the video just a little bit.
You don't think the register our Professor Sherif Emil. I remember when Professor Ahmed sent me a message. There are people you don't take their messages for granted because once the messages come, it's something for the good of both you yourself and those who are surrounding you. And he asked me, can Abson accept to host and mount the trick course? That there's a proposal, but the proposal hadn't gone out. And that was before our annual general meeting of last year. And I told him that it's something I was going to relate to the National Executive Committee, but that he should be rest assured that we're going to grab it with both hands. I also remember that in the last Abson AGM in Lagos, it was brought to the AGM and we discussed about it, and Abson unanimously accepted to host the trick course. And here we are, we have held the trick course in Nigeria. Can we put our hands together?
For me, that was really the validation that I needed because they were so proud. They were so proud to have been able to host that course. And following our course and our time there, within days, they had already put groups together that are going to be the champions for the course. They already have plans for the next course. And for me, that was really the proof in the pudding that we had done it right. We had partnered them. We had made sure that they have buy-in, that this is something they want to do. And it was really just such a pleasure. I'm going to shift a little bit more now to a different type of education, and that is exchanges, something I've been very engaged in also for the last 10, 15 years. When I came here in 2008, one of my first projects was to try to get our fellow a rotation in Kenya. I had visited Dan a couple of times, had operated with him there in Kijabi, was really impressed with the hospital and its structure and how it ran. And of course, Dan was a pioneer. He really created the first pediatric surgical training programs in the area. And it was had changed the landscape, not just in Kenya, but throughout sub-Saharan Africa. And I so wanted our fellow to experience that environment. So we created a fellowship, and Rob Baird went, and within months we made it an exchange. And here in the middle, you see Dr. Ferhun Ayali, who was our first fellow, who's actually Ethiopian, but was training in Kenya and was hosted by one of my patients' families, who gave him a place in their home to stay in, because we still didn't have great funding. Since then, we now have very solid funding for this program. And we put a lot of thought into it at the beginning, and it was never about our fellow just going to operate on a bunch of cases or see things that they haven't seen. Yes, we knew that they're going to see pathology that is rare or absent, and that was a definite plus. But really, most of the objectives was to experience the environment, to understand what it means to work in a less resource setting, to gain exposure to education in that setting, to have an appreciation for the challenges that exist. And some of those appreciations end up being reverse innovation, like actually bringing back ideas that could benefit us here and so on. And we created an infrastructure that met all the American Board of Surgery criteria. There were really no Royal College criteria at the time for this kind of thing. I don't know if there are now, but the American Board of Surgery had very specific criteria for general surgery rotations, and we really did exactly what they had prescribed to be able to do this. And 5 years later, after 5 of our fellows had gone and 5 of their fellows had come, we evaluated the program, and we both looked at the outcomes, and the education outcomes were pretty good, although in general, they were a bit better for the Montreal fellow than for the Kijabi fellow. But we also looked at the burden of such a program, housing, financial burden, and you can see that the burden was definitely higher for the fellows who came from Kenya than for our fellows who went to Kenya. And this was really important to know, because we were very proud of this program, but it definitely needed some work. So at that time, we were really, this was kind of like one of our flagship programs in our training. And yet, around the same time, the American Board of Surgery and the ACGME decided that should not be allowed. And they had actually stopped all Canadian programs from being able to do, for all the American programs from being able to do that. We could do it because we had Royal College accreditation. And so Dan and I, with Dr. O'Neill, who is really one of the giants of this field, we wrote this editorial, and we addressed all the issues that the American Board of Surgery had brought up. The pediatric surgical training is too short. Well, they were worried that the trainee is going to go for a month, but trainees spend a total of 2 years anyway. And we addressed all of these issues, and we showed that none of them really had any evidence behind them. And sometimes you have to bring something to the surface, because it's just you're being a catalyst. And this is how we were. We were a catalyst, and then people started writing, and many fellows wrote letters to the Journal of Pediatric Surgery. Some really major figures like Duruk Ozgediz, and wrote in and supported our position. And we continued to argue for that position, despite many telling us to kind of lay low, because our program might get in trouble and so on. And finally, we had what I call education practice change. In spring of 2022, the ABS and the ACGME allowed incorporation of up to 4 weeks of an approved international elective. And Indiana University just became the first program in the US to have a 4-week rotation for their fellow in Kijabi, approved by the ABS. So we no longer have to be doing anything under the surface. But at the same time, even as we're arguing for this, we had to look at our own experience. And a new program director had come in to Kijabi, a Kenyan, one of the fellows who actually rotated with us, and did not feel that this rotation was still useful for their fellows. And, personally, I was super invested in this, but my first reaction was, we will do whatever you guys think is best for you. So I visited Kijabi last year, and the American surgeons who were there were very, very excited about continuing this, but the program director was not. And so we entered into a series of conversations and exchanges and finally had a meeting. And before I get to what we ended up, I just want to kind of give you a bit of an idea of what sort of outcomes come out of an exchange like this. This is Edmund. Edmund was the Rwandan surgeon who was one of the Kijabi fellows who came with us. I got to meet Edmund in my first trip to Rwanda. They only had these small scrubs, and I got incarcerated in one of them. So he got a pair of scissors to try to free me from my scrubs. We became really close friends, worked with him on a number of difficult cases. And it was really nice, again, to be working with a local surgeon who was personally invested in their environment and really wanting to do the best. And I, always send these dispatches, and at the time I was doing it on the MCH website, and I wrote a blog about him because I was so impressed with his energy and his dedication to his people. But relationships beget relationships. So here I am working with Edmund. Robin Petrosi at the time was the University of Virginia resident who was doing her research in Rwanda, and we had a Harvard team of anesthesia people. Edmund came, and this is us apple picking with my daughter, very young at the time. Robin went back and went on the Kijabi exchange and ended up working with him actually locally in Kijabi. They formed a tremendous partnership that continues to this day. And one of the patients that we had when I was in Rwanda was a gastroschisis patient. In 2013, there has not been a single survivor of gastroschisis in Rwanda. Not a single baby had survived. And we thought we were going to get our first survivor, and unfortunately, we did everything we could with the resources we had, but still lost the baby. Through the partnership that Edmund and Robin have had, they have now reported it's actually coming up close to a 50% survival of gastroschisis babies. So these things really do make a difference, and they do make a difference to patients. But for our exchange with Kijabi going forward, we have changed it according to how they feel they would benefit. So our fellow would still go to Kijabi, and they're welcoming our fellow during a time when one of their fellows would be offsite. But now, instead of getting their fellow during training, they want their new graduate to come for a 4 to 6 week observership as a young attending. They feel they would benefit more from that than from coming as a resident, and that is what we'll do. And we will be hosting, again, their first graduate coming this May here in Montreal. Now, shifting again to a very different, I'm sorry, I'm kind of all over the place, but I'm hoping within the next 15, 20 minutes, you'll be able to see that there's a theme that weaves through all this. One of my pet peeves is that surgical education can be very expensive. I mean, this is, the book, our Bible that Jean Martin mentioned, he's one of the editors. And you just look at the price of the book. I mean, there is no African trainee or practicing surgeon who's going to pay $350 to buy the classic book in pediatric surgery. That's just not going to happen. I am very fortunate. I'll be the next editor of this book. And my very first discussion with the publisher was, I will only take the job if you promise me we're going to have a way to have this accessible to surgeons in low-income countries for minimal pricing. And that's where we're at. And we are now coming up with different models to be able to do that. But we have to do that. People on this call write chapters, participate, publish books. We have to ask the publishers a question: how are we going to get this in the hands of surgeons who cannot afford it? Now, to be very honest, a lot of these books are pirated. Okay, I mean, you can probably go and search and get pirated books, but we do not want to encourage that. We do not want surgeons in low-income countries to feel like they have to resort to crime to get this knowledge. And, even books that are published for Africa are not inexpensive. So again, like, no African trainee is going to pay this amount to get a book that is meant for them. Now, again, there have been some private efforts to try to get these books to trainees, and this was really through the personal efforts of some surgeons, but we just have to think of this as a major issue. So this is my pride of joy. I mean, my partners will probably now be snickering and laughing because I talk about my book a lot, but it was, a 4-year effort that really was a bit of miraculous to finally come out. And the book came out in September 2019. And of course, we know what happened a few months after that. COVID hit, nobody was traveling. And I was really thinking, like, how do I get this in the hands of people who need it? And so I did 2 different things that I consider global surgery from home, from right here in my office. One is I I started taking the book and translating it into episodes, which I called CB clips, or case-based clinical learning in pediatric surgery. And each episode was divided into 2 posts. I would introduce a clinical case and inquire about its management, and then I would give people a chance to interact and then produce a video commentary with the case management. And it was great because it took the audience participation into account. So people from different parts of the world, overwhelmingly from LMICs, would talk about how they would manage this in their environment, and then we would bring the whole thing together. And, the reach of this kind of program absolutely shocked me. I was in Jean Martin's next to his cottage on July 1, 2020, and I put the first episode, and 6 hours later, there were close to 10,000 impressions on Twitter. Now, you cannot get this kind of reach with anything we do locally. And even 28 episodes later, within a few hours, you see the amount, the reach that this can have. And, people don't comment much on Twitter because of the limited capacity, but they comment on Facebook. And you see the type of commentary, and much of that comes from people in low and middle income countries. And it really creates a learning community. We just concluded a study trying to evaluate the international impact of this. And we got people from 71 countries, about 75% of them low and middle income countries, to give us their input. And you can see some of the results here. For many, it really became a significant source of ongoing education, and leading to changes in practice, leading to knowledge applications, and the overwhelming majority would recommend it to others. Then the other way I thought I'd wanted to do it is to how do I actually get the book in the hands of people who are not going to buy it? And this was thanks to the foundation, Marilyn Lino Saputo Foundation, that supports my chair. They actually gave me a grant. So we worked with the publisher to have a joint effort so that the publisher was going to send it for free. They printed a copy that was a little bit less expensive than the hardcover copies that the book typically comes in. And we created an application process. And after I sent the first group of books, Mark Levitt, who's a really good friend in DC, who's really the premier colorectal surgeon in the world now, he had a bunch of smaller books concentrated on colorectal surgery. And Mark couldn't travel either at the time. So he said, can I join you? And so we created a library of books, his books and my book, and we got a grant from his foundation. And we started sending these books out, specific criteria. People had to apply and show us why they needed the book and what they're going to do with it. And these were our criteria for book gifting. And we kept that program going for 3 years. And it was really absolutely amazing. I could not have foreseen, and it had nothing to do with just a bunch of books being sent out. I mean, the books are going to get old, the knowledge is going to get old. So that's not the point. The point is that we created an incredible community of surgeons that we would have never known about. We were able to get this book into the hands of 3,500 recipients in 80 countries, 270 institutions, and really meet surgeons who were struggling for knowledge and to be able to use that knowledge in their practice. And it led to amazing new partnerships. Dr. Nasarov was a up-and-coming pediatric surgeon in Uzbekistan who essentially became like an attachment to our division. He joins our weekly conference every week. He runs cases by us when he has challenges, etc. Same thing with Dr. Gabriel Villa in the Philippines, and multiple people who would email me and Mark almost on a weekly basis asking for help with cases and so on. And then groups that I would have never visited. I would have never known what they do, like, group in Quito, Ecuador, and looking at so many young surgeons and upcoming residents who love the idea of having an interaction and be able to have a voice in saying how cases are done. And then partnering with groups that were doing their own amazing work, like Milan Chitnis in South Africa, who actually during COVID started to do the same thing and do a lot of online education and so on. And now we exchange educational activities by my participating in their teaching sessions and so on. And then we went a bit further, and because Mansour and others were joining our SRP and finding tremendous benefit. This is a conference that we've had for 40 years. Many of you have attended it when you were residents. It was very successful. And we then thought, okay, if this is so useful, why don't we globalize it? So through the Hendren projects and working with this wonderful educational foundation, now once a month, we take our Hendren project and we globalize it. And we globalize it in a way of being interactive. And we don't globalize it in like, here's what we do and here's what you should do. We actually open it to people who are joining us from all over the world and ask them, like, how would you do this in your own environment? What kind of things would you think about? And this is what I mean, but we all learn together. It becomes like a really a democratic way of sharing knowledge and participating in knowledge advancement. And you can see here, this is one of our global SRP sessions. This is the kind of reach, 59 countries, 204 participants. When you look at this list of countries, yes, there are some countries, there's a lot of Canadians, some Americans, but if you look at this list of countries, it's overwhelmingly trainees and surgeons from low and middle income countries. So the reach is absolutely amazing. How can we help our LMIC colleagues feel valued and appreciated on the international stage? Now, we all go to conferences, we have seminars, we have webinars, but how often do you see a surgeon from a low-income country actually participating as faculty? We often think of trainees and surgeons as knowledge consumers, but so many of them have tremendous knowledge to share. And one of the things I've done through the Hendron Project when we have other webinars is to make sure that we have faculty coming from low-income countries, both to give them exposure, especially young faculty who do not have access to a lot of exposure, and to make sure that this is a shared experience, that we are sharing our entire experience as a world. And I have been so thrilled to actually take surgeons like Emiliana Lee, a young surgeon in Indonesia who, again, like really up and coming and very involved and wants to be very academic, and letting her become the presenter. And I've had now surgeons from Lebanon and surgeons from Brazil do this, and it's a pleasure to help them actually have that kind of impact. Another experience that I've been very involved in is the visiting scholar programs. There is not a lot of literature. We're now doing a study from the Canadian Association of Pediatric Surgery Global Surgery Committee on to evaluate this, but there is some evidence that these actually do have some long-lasting experience. Now, the program I've been most associated with is through the Pacific Association of Pediatric Surgeons, because it's named after Dr. Worden, who was my predecessor at University of California, Irvine, a Canadian surgeon who had worked in California all his life, and really somebody who was a tremendous example for me as a resident. The thing about these programs is people look at them as, okay, well, what has the fellow done afterwards and so on. But these programs are about relationships, and relationships can save lives, literally save lives. And I can speak about this because Dunya actually wrote her experience in the Journal of Pediatric Surgery. Dunya was an Afghani surgeon that I invited to come to New Zealand as a visiting scholar back in 2018 or 2019. And we got to know her through that relationship. This is Marilyn Butler. And when the Taliban took over, Dunya was operating and had to finish as quickly as possible and essentially go into hiding. And she relates her experience. From 2 months, she was going from one place to another trying to evade the Taliban. And it was really Marilyn Butler and the support from PAPS that helped Dunya get out of Pakistan, as well as her colleague, who was also one of our fellows in PAPS. And those relationships can also change lives. Dunya eventually became one of our Jean Martin Global Surgery Fellows. You see her here with some of our other trainees. And she's now starting her career in Canada, doing some amazing research work. And I have no doubt that she will finally find her way into practice in Canada. So that's what these kinds of programs do. They plant seeds. And to my pleasure is that I'm very proud of the PAPS, because PAPS has made a conscious effort to hold their conferences in low-income countries. We talk a lot about wanting to involve our colleagues from low-income countries, and then we hold these conferences in cities where the hotel costs $500 a night. I mean, they're not going to come to meetings like that, So PAPS 2 years in a row went from Ecuador to Indonesia, very reasonable hotel costs, very reasonable prices in general. And again, these were our 2 fellows from Indonesia. And for the first time, one of our visitors became the host. And so Emiliana actually hosted the 2 fellows coming from Thailand and Mexico at her institution the following year. And this was, to me, how we should do it. We need to be going in both directions. It can't always be just people in the north bringing people in the south to their institution. Now, the other little bit of a pet peeve I have is that we do a lot of talking about, wanting to be inclusive and helping our colleagues, but we don't put our money where our mouth is. And this last year, I engaged with our own organization, the Canadian Association of Pediatric Surgery, because the visiting scholar program was very poorly funded. The funding hadn't changed in 10 years, even as all the costs had gone up. And we were always trying to find ways around it and, find ways for our visiting fellow to room with somebody else and et cetera. And it was almost like, okay, we're sort of doing you guys a favor by keeping this program going. So with strong support from our committee in global surgery at CAPS, I just presented and mend it or end it. It's not appropriate. Either we really do this right or we just end the program. And to CAPS credit, they really improved the program substantially to where we can continue it in a healthier direction. And I showed them that it's not about a fellow coming to Canada and then leaving a few days later. I showed them very strong examples of how almost all the fellows who have visited us, we continue to work with them in their own countries, educationally, helping them with service, helping them with capacity building, et cetera. This is our last CAPS Global Visiting Scholar, Dr. Sam Nagash, who spent a week here with us at the Children's. And this is the kind of interaction we have. Sam is a pediatric surgeon, the only pediatric surgeon in a huge hospital in Ethiopia. And yet, when you look at what he's doing, what he's trying to build, you look at his bibliography, it is humbling that he can do what he can do with the resources he can. We need to support these surgeons in any way we can. And after spending a week with us, it doesn't end there. Our relationship will continue. We're now talking about other potential projects we can do together and so on. In the 15 years I was chief, there was a lot of projects I'd been very proud of, but not many more than the Jean-Martin Laberge Fellowship in Global Pediatric Surgical Research, partly because I really wanted to honor Jean-Martin's legacy to the Children's and to McGill and to surgery, and to build a program that would really, make us distinct in terms of how we're going about in terms of capacity building. I'm really, really proud. I envisioned this program in 2017, helped fund it. And the way we started it is we ourselves within the division committed a significant amount. And then we asked our fellows, our graduates, to match that amount. And there was a wonderful family whose child Jean-Martin had taken care of who matched all the contributions. And so we actually were able to, within a reasonably short amount of time, raise about $300,000 to start this program. And I'm not involved with this program any longer, but I have been, I've been worried myself about how quickly it's growing and the funding, but Dan, who now runs the program, has proven me wrong. We now have, these are our fellows who have come through the program. We have now 4 or 5 at the same time, and they're all really doing amazing work. They're really all emerging international leaders in global surgery. The program is thriving and is really just an absolute pleasure to have. I'll finish up with going a bit more now towards service, working with Mercy Ships. One of the things I've really tried to do in my work with Mercy Ships, with all of that context in mind that I've already spoken about, is that we engage in mutual mentoring. It was quite interesting because many of the countries I've gone to with Mercy Ships actually have had some of our Kijabi exchange graduates. This is Yurik Rokatumala, one of the Kijabi fellows. This is George Nock from Cameroon, who rotated with us. George and I are doing a large sacrococcygeal teratoma together there. I've also looked at, Mercy Ships. I'm so honored to be part of their organization. They are really a reflective organization that does not have any trouble asking the more difficult question. This is an interesting paper that came from the experience in Benin, where investigators, people who'd worked with the organization, conducted interviews with patients, and the patients, their very strong themes came out. Patients were not able to have local surgery because they just couldn't afford it. It was not available to them free of charge, and they could not afford it. The experience on the ship was incredibly positive. And I think if any of you ever step foot on one of these ships, you'll understand what I mean. It's an environment like no other. And many of these patients were so intimidated by surgery, and going through a surgical experience changed their perspectives on surgery. But the downside was it did create further distrust of the local surgical teams. And this is a difficult issue because how do we take care of patients without decreasing the credibility of their own surgical team. So that has been very much on my mind. And one of the things I've been able to get through Mercy Ships for pediatric surgery is to encourage surgeons not to come just as mentees, but to actually come as volunteers. And in order to do that, we cannot do what we do coming from Canada or the US or Europe, as many of the pediatric surgeons who come to Mercy Ships do, where we do it completely as volunteers, and we're happy to let go of our income here in Canada when we do that and so on, and we can afford it. But an African surgeon cannot afford to just simply come in for 2 weeks and leave their, oftentimes they're working month to month to meet their needs. So this program will cover their travel and lodging expenses, gives them a stipend to compensate for the lost income. We also will look at the effect on their own practice and make sure that they're not leaving their own patients behind. And then we will pair the surgeons with expatriate surgeons to have knowledge sharing and mutual mentoring. And now, in the last couple of years, we've not just had surgeons from high-income countries, but surgeons from Brazil, India, Egypt, and Cambodia, all in the talent pool. And we had our first Brazilian surgeon come in from Brazil as a volunteer. And that just has really been wonderful. I've also felt very strongly about integrating trainees in an inclusive approach. This has also come under quite a bit of critique. Do our trainees go and take work from local trainees and from local surgeons? And, that's kind of like a whole other topic that I could speak about for an hour. But there are ways to do it in a very inclusive approach. Here you see many of our fellows, Yasmin Youssef, Etienne, when he was doing his research with us, Katie LaRusso, many of the residents you've worked with, typically they come during the research years with me because I think that's the right time for them experience. And why am I so passionate about this? Well, when we were in Cambodia, Etienne and I were blogging on the Royal College Facebook page, and I'm just going to read you what I said. I said, many trainees come to the African Mercy with their attending staff. The experience cannot be duplicated on a training environment. They will see late presentations of disease. They will understand the effect of poverty, abject poverty on health and life. They will learn to manage fragile patients. They will have to make difficult decisions. They will have to function well outside their comfort zone. But most importantly, they will see altruism not just lectured and spoken about, but lived every moment of every day. They will experience the healing power of common purpose and common vision, not just to patients, but also to us who take care of them. And that really remains my passion. And service and capacity building are not mutually exclusive. This is Alois Sagna, who is a Senegalese surgeon who have really become a close partner and good friend. And we worked out our Mercy Ships experience so that we also do workshops on land, and we ran an anorectal malformation workshop and operated with his residents and with his team at his hospital, and then had experiences on Mercy Ships. And it was just a pleasure to combine that together, and our relationship continues very strongly. So to finish up, what are the lessons? I think for me, this journey has taught me that it's about seeking, listening, including, empowering, and sharing. We should implicate our partners in all planning of global surgery projects from the get-go, not once the project is a reality and now let's find partners, from the get-go, from the design of any project. We should seek the input of these partners throughout the process of implementation of global surgery projects, empower them as providers, not just consumers of surgical education, help them experience the joy of volunteerism. All of us who volunteered know how joyful that is, and they should be able to experience the same joy. And then for all of you, you are part of fantastic department, fantastic educational activities. Think about who can you share this with? Who can join you on some of these educational activities if you're doing them online? I'm proud to carry Dr. DeBass's name as the holder of his prize here at McGill. And I think if we do this right, we could do what Dr. DeBass envisioned. This can be a win-win for us and for our partners in LMICs. I'm going to finish with a couple of very personal slides. So big reveal. Yesterday, I had my 60th birthday. And this last year has really been a year of quite intense reflection for me. It's been a year of transitions, a year of change, a year of many events, most fortunate, some unfortunate. And it's given me a chance to reflect on my experience in global surgery and how it actually affects my experience overall as a person and a human being and a surgeon. So I just want to share some personal lessons. We all want to learn. We live in an incredibly polarized world that is disturbed and violent. And I think one of the few things that actually brings us together is the desire to learn. I put these two pictures together because they're taken just a few months apart. I was a visiting professor at the Cleveland Clinic and then at Kenyatta Hospital, rounding with residents on their service, and the passion is the same. People are in very different environments, extremely different environments, but the passion to learn and to advance is really the same. So that passion, we need to always take advantage of it. For those of us who go often to low-income countries, it can be a bit discouraging. You go year to year and you don't see much change. But if you take the bigger picture, it is incredible, and you just need to be patient. This is the hospital I used to go to quite often in Nairobi. It was like basically one large ward with a couple of apartments, and the operating room was like a garage. And in 2023, this is the hospital now. It is an incredibly thriving hospital with a neonatal intensive care unit, a pediatric intensive care unit, adult intensive care unit. Incredible progress has occurred. And this last few weeks when I was in Nigeria, I remember my parents being two of about 15 doctors for an entire state and going to places where they were the only doctors often in some of the smaller cities in Kwara State. And then being there, seeing a university, seeing a medical school, seeing a sim center, progress is happening, does happen, and we just need to be patient to see it. It all comes down to one patient at a time, one learner at a time. Whether we're right here at the MUHC or halfway across the world, this has to be our focus, and then we go back to what we started with. We talk a lot about equity. This is part and parcel of global surgery. We need to do a little bit less talking and a little bit more doing. This is in 2021, an article came from the American College of Surgeons talking about equity vocabulary. Had all these 4 pages of how you should use equity vocabulary, and I really was stunned. I have tremendous respect for the American College of Surgeons. I'm a member of the American College of Surgeons. They've never endorsed a healthcare for all model, ever. So it's very hard to have equity vocabulary when you're not willing to endorse an equity system of taking care of patients. And we have our own problems in Canada as well. And I talked about that in this article. So I think we just, we sometimes take comfort in having all this vocabulary and practices that don't really translate to anything on the ground. And I think we need to all be resistant to that. And finally, and I left the slide till the very end because I figured if I showed at the beginning, I might lose half of you. I think words do matter. We see words like surgical colonialism, surgical adventurism, neocolonialism, decolonization, savior complex. Now, I'm not denigrating those words. I think they raise important issues, but they also, I don't know how to say this, but they do discredit so many people who've put in so many efforts to improve the health of patients. Now, some of those people may have made bad decisions, just like we probably have made bad decisions for our patients right here. But it doesn't mean that what they did was meant for bad intentions. And a lot of this implies bad intentions. And it also, to me, and this is very personal, a lot of people disagree with me, and I completely respect the different viewpoint on this. But when I see this child in Guinea, whose mother is hiding her from the family because of this tumor that has been growing since she was a baby, obviously benign because she's still alive and thriving, has completely deformed her chest. And now the child has no future. She cannot go to school. She will never get married, which is a big deal that parents of African girls will think about. And she will never have a future. Or this child in Togo who has a massive sacrococcygeal teratoma and is in a tiny bush hospital. You could criticize me and say that if I approach these types of things, then I'm engaging in a surgical adventure. But to the families of these children, it's their only hope of having a semblance of a life. So, sometimes I feel we're just being very judgmental, and we disincentivize so many people who want to participate and are now intimidated by these types of words. And I think that's unfortunate. I think we can do better. Let's talk about the issues just as I've spoken here, but let's be careful about what kind of words. There are thousands of patients alive in Africa and other low-income countries today, and probably tens of thousands of patients alive without disability for no other reason, most likely, than a surgeon left their comfort zone and went and took care of them. And that's just a fact. So it's about making good decisions. And sometimes we don't make the good decision. I mean, this is, again, universal, whether we're practicing here or there. Hopefully, we make the best of decisions all the time, but the decisions are never easy because you have a human being in front of you who is really suffering. And we just need to remember that dimension. I want to thank so many people who've really helped me, and specifically 3 foundations, the Monahan Desotel Group, which has helped fund a lot of my global surgery work, Merrill and Lino Saputo Foundation that funds my chair, and the Ski for the Children that has really started the fund for our Jean-Martin Laberge project, and so many educational organizations, the Foundation of the Montreal Children's Hospital that helped channel a lot of these funds, and the Royal College and Mercy Ships and the Hendren Project. I'll leave you with these two of my favorite quotes, scripture verse and the Winston Churchill quote. And I think I went about 5 minutes over my time, but if there are people who are willing to stay, I'm more than happy to answer any questions, and I will look at the chat. Thank you so much.
Thank you very much, Sherif, for this talk. I'm taking over from Alina, who had to go to the OR. I actually feel very much the need to say that, yes, this was a giant talk from a giant person that you are. And when that happens, there's always surprises. And I have to confess that I sort of thought, I know what Sherif is going to talk about. And I was surprised, and it was a beautiful surprise. You do the way that you have brought together all these multiple aspects of your work, very varied aspects of your work, together into this talk, into a thread, was really, really unforgettable. So thank you for that. We have a few minutes. Apparently, we can go on till 8:45. So if there are any questions, you can go directly on, put your hand up, and we'll let you speak, or you can put it in the chat, and we will indeed monitor the chat.
Thank you, Dan.
Dan.
Phenomenal talk. Again, it's incredibly inspiring, and it's an incredible amount of work, all with the right intentions, but also with the incredible amount of humility. So thank you for that incredible career. And obviously, you're young and not done yet. So look forward to hearing about more
Thanks,
of the
Dan.
future.
I really appreciate that.
And I've been thinking, the last 4 to 5 years have really been, as you said, quite tumultuous in this world, and if anything, we've become more and more polarized. And as physicians, we really do have the privilege to see and advocate beyond just medicine, because we recognize what are some of the important values that get shattered when health gets shattered. And I wonder if you've been able to use that privilege to speak a little bit more about tolerance, about communication, not being political. It's important to recognize that, not being political, but really going back to because I do think we are quite privileged to see that. So have you been able to sort of translate that into other things outside of medicine? Yeah.
So Dan, thank you so much. I didn't think this question would be posed, and I'm very happy you posed it. So first of all, thank you for the compliment about my age. I told my wife yesterday, I'm very excited because now I can take advantage of so many discounts. So that's that's one good thing about getting to this point. So Dan, I mean, it's probably not a secret to you that I've written a lot about things that don't seem to have a medical implication. I've done that publicly. And the reason I do that is I do believe two things. One is that so many of the things we consider as, potentially a social practice or a cultural practice, I do think it has a significant effect, especially as a pediatric surgeon, on the health and development and well-being of children, even if it does not seem to be immediately related to health. And second is, I do believe we have a voice that people respect. I do believe people believe that we have the best intentions and that we have a right, we have a need to speak about things that we don't believe are appropriate. And unfortunately, whenever you step into that arena, you are inviting controversy. And, that is a difficult thing because in a polarized world, people do not want to see the nuances of what you're writing or speaking about. They simply want the headline. So the challenge becomes how to participate without causing further polarization. I think that's really the challenge because what you do, if it's not done carefully, can cause further polarization. I have lived through that. I've lived very difficult moments where, because of what I advocated for, my life was in jeopardy. My family's life was in jeopardy. I mean, this is not theoretical to me. But we have to continue to do that. And we have to insist that we approach this not from a political standpoint. We approach this from a point of advocacy. If we advocate for certain practices, if we talk about the rights of girls in some societies, and are they getting the healthcare they need, as some of our researchers are doing right now, looking at gender disequity in already an environment that is inherently unequal. We need to approach this from an advocacy standpoint, that we are advocating for our patients, whether they be here or halfway around the world. But I don't have an easy answer. It is very, very challenging to be a physician and surgeon and be out in the public environment, in the public domain. For most of my colleagues, they probably think I'm crazy to do that, and then I'm inviting, trouble. And they're right. In many ways, I have, but I don't think I will stop that. I think I will continue to be engaged, and I invite everyone to think of it. What are they passionate about that they see? And I think we need to be continuing to be involved in that sphere.
Thank you.
There are a few comments, simply compliments, Sherif, in the chat for the talk as people are sort of moving on. If I don't see any other hands up or from anybody. Maybe this is a good time to sort of bring it to an end. And once again, thank you, Sherif. I think that this talk will stay with us for a while, and we really appreciate what you're doing, and we can only wish you the best in the new journey. You're 60, and this is you just took up a new position. So all the best in that. We'll be looking from the sides to see how that all that you'll be doing. So thanks very much, and thanks for everybody who attended. It was a great morning, and we hope to do these joint rounds indeed on a regular basis in the future. Goodbye,
Thank you.
everyone.
Bye.